Welcome back. In video 3.1, we are going to look more at rhythm and pay attention to tachycardias that arise from above the ventricles and are mostly regular in nature. In the previous video, we talked about how there are numerous ectopic foci stationed throughout the heart that can serve as backup pacemakers in the event that there is a prolonged sinus pause or sinus arrest. We talked about how those pacemakers can also be activated early in the cardiac cycle and can produce what we refer to as ectopy. And these are things like premature atrial contractions and premature ventricular contractions. We talked about how these premature beats can occur isolated, just one here or there, or they can be multifocal, or they can even occur in a pattern like bigeminy or trigeminy. Also, we discussed how if a particular ectopic focus outside of the sinoatrial node became enhanced in its automaticity, it could persist to initiate a tachycardia like the one shown here. The first and most important distinction in the tachycardias is this. Ventricular tachycardias are those coming from the ventricles, and then those arising from above the ventricles. Those that occur above the ventricles generally are going to be narrow complex, with a few exceptions, and then ventricular tachycardias are generally going to always be wide complex. There are significant differences in how we care for these patients, and we'll talk more about both of these groups of tachycardias. Now, in terms of causes of tachycardias, not in terms of where they come from in the heart, we have the two mechanisms. One we've already talked about, that's enhanced automaticity, and then the other one is re-entry. As we have discussed, enhanced automaticity entails a particular ectopic focus being overstimulated, whether it's a normal extra beat or whether it's the result of some kind of disease process or exposure to toxin, so that ectopic focus persists in its automaticity to produce some kind of tachycardia. The other mechanism we discussed is re-entry. This is where there is an extra pathway located either in the AV node or a direct connection between the atrium and ventricle itself. So here is a framework for coming to terms with the tachycardias. By definition, they need to be above 100 in terms of rate, and then we have those that are ventricular and then those that arise above the ventricle that are generally narrow complex. Subsequently, we can also divide these into regular and irregular tachycardias. Let's look at the regular ones first. On the regular side, we have first ectopic atrial tachycardia. We can see here that there's going to be a rate above 100 and that there's going to be inverted P waves. Then we have atrial flutter. Here we're going to have a high heart rate. It's going to be regular for the most part, but occasionally can be irregular, and that's why there is an asterisk by atrial flutter. In lower rates on atrial flutter, we will be able to see that there are more P waves per QRS complex, and that sometimes we can identify the so-called sawtooth pattern. And then the last of the regular tachycardias that arise from above the ventricles is going to be supraventricular tachycardia, in which we have a regular, narrow complex, fast rhythm greater than 100, in which there are no discernible sinus P waves. Looking first at atrial tachycardia, this is caused typically by an ectopic focus in the atria. This produces a rate of 100 to 250, but usually the rate's less than 200. And when we look at the EKG, we're going to see something like a uniform non-sinus P wave. What we mean by that is if you look in the left lower hand area here, you can see what is going to be something in like lead 2, and here we have an inverted P wave, a QRS complex, and a T wave. So if we look at this, let's take a look at this 12 lead EKG. First, we're going to do the rate. We're going to come down to our rhythm strip, and we're going to find a QRS complex that falls on the heavy hatch mark. This one we'll do right here, and we're going to count our rate 300, 150, 100. So it is slightly faster than 100, probably by 3 small boxes with each representing 10. So I will estimate the rate to be 130. Now for rhythm, we're going to come right up here and we're going to look in lead 2. And what we're going to see in lead 2 is a QRS complex and what looks like an upright QRS complex, an upright T wave, and out before it is this inverted wave, which presumably is the P wave. For confirmation, we would come to AVR, and here we can see an inverted QRS complex, an inverted T wave. And what do we think of the P wave here? It's hard to see, but if we were to zoom in on that, we would be able to see a positively deflected P wave. That is exactly what we should see in ectopic atrial tachycardia. narrow complex, quite regular, and then P waves that are not sinus and morphology, but only one type of P wave. They need to be uniform. Typically, it's just going to be the inverted P wave in lead 2. Next up is going to be atrial flutter. This is caused by an ectopic circuit in the right atrium and is usually associated with some kind of underlying cardiovascular disease. Now, there are two rates that we need to consider with atrial flutter. First is the atrial rate, which typically is going to be discharging as a result of this fluttering foci at a rate of 300. Then there is the ventricular response. The ventricular response depends upon the degree to which the AV node permits the conduction of these numerous ectopic flutter waves. With that in mind, it is possible for a patient to have a heart rate in around 300, but of course that's not consistent with cardiac output and that is not sustainable. If we see a rate around 150, we're going to usually see a narrow complex tachycardia that's quite regular, and it's going to be hard for us to find the flutter waves. But as the rate comes down, these flutter waves are going to be more evident, and we're going to be able to see that there are several P waves per every QRS complex, and then sawtooth pattern in the lower rates also. Let's look at our rhythm strip on this 12-lead EKG. Here we can see there is a QRS right here on this hatch mark, and so we'll do our count 300 to 150. The rate is 150, and that's important because anytime we see a narrow complex tachycardia and the rate falls around one of those hallmarks, 300, 150, 175, 60, 50, 43, we should consider atrial flutter because it tends to express rates, ventricular response rates that cluster around those hallmark heart rates. So here we have a 150. That is our rate. The next step is to look for the rhythm. We're going to come up here and look in lead 2, and this is very tricky. We see something that looks like a mostly negatively deflected QRS complex, and then here this one looks different. This one looks the same, this one looks the same, this one looks the same. So let's see if we can find what looks like a P wave. Well, I can't tell if that's a P wave or a preceding T wave, and the same thing goes for this. And then there's this weird bump right here that kind of comes in the tail end of this QRS complex. It is hard to say if there are any sinus P waves. When we look in AVR, we're also having a hard time finding anything that satisfies the indication of a sinus P wave. Now in V1, the rate does slow down. You can see here through the anterior leads so that I see these two spiked things right here, and those probably represent flutter P waves. Now, having said that, it is very difficult to distinguish this from other tachydysrhythmias when the rate is around 150, but for our purposes here, this is going to be atrial flutter with 2-to-1 conduction. If you look at this strip here, we can look in V1 here, and let's look at the rate. We have 300, 150, 100, 75, 60, 50, 43. Interesting that the rate is exactly on one of our hallmark heart rates. Also, if we look for the rhythm in V2 or in lead 2, we're going to see this sawtooth pattern where there are 3 to 4 P waves before every QRS complex. This, of course, is atrial flutter, and either with treatment or with vagal maneuvers or whatever, the ventricular response has been slowed down enough that we can see that sawtooth baseline and be confident in making the diagnosis of atrial flutter. So with that in mind, we can see where it would be very easy to confuse ectopic atrial rhythm versus atrial flutter with 2-to-1 conduction ratio, and I'll just say it's not that easy. In the matter of atrial flutter, it will be helpful if the heart rate ends up being around one of those hallmark heart rate. So if our heart rate over here is 150, and it is, then we'll automatically think this could be a flutter. Next, have a look for P waves, QRS complex, and T waves, and that's going to be very tricky because the area of the P wave and the T wave are both occupied by the same inverted wave. Now you can see these complexes all look fairly similar, but this one has what looks like it might be a P wave tucked inside the end of a QRS complex. Now we can't say that with any confidence, but I can say something like, well, if that is a P wave and then this is a P wave, then the rate's going to be somewhere around 300 because they are so close together. However, if we look at this side over here, the rate is more like around 130, and then if we look at this complex, we can see that there is an inverted P wave, a QRS complex that's upright, and then a T wave that is upright. We verify that the leads are all in place. We can be confident in saying that this is ectopic atrial tachycardia. So again, in atrial flutter, you can see in the top panel, here we have leads 1, 2, and 3, all displaying a patient in atrial flutter. Of course, the rate here is about 150, and so it's just so hard to make any judgment about if there are P waves or if there are any T waves or what's going on here. And you can look down here in panel B and see that somebody has applied carotid massage. We will talk about that later, its indications and contraindications. But as a result of carotid massage and an increase in that vagal tone associated with it, it slowed the ventricular response and the AV conduction down. And now that you can see all of these crazy flutter waves that are creating that sawtooth baseline. Next up is supraventricular tachycardia. Now this tachyarrhythmia is the result of re-entry, and it can be re-entry through the node or a direct pathway that connects the atria and ventricles. This will produce a narrow, complex, and quite regular tachycardia that can range anywhere from the 160s to 200s, and as we said previously, there will be no discernible sinus P waves. The first type of tachycardia we're going to talk about is the accessory node pathway form AV node reentry tachycardia. It represents the majority of supraventricular tachycardias and also the PSVTs or paroxysmal supraventricular tachycardias. Quite simply, a paroxysm is a sudden occurrence, and so a PSVT is sudden occurrences of supraventricular tachycardia. So let's look a little bit more into the nodal origins. Here we have a normal heart in a normal patient, and we can see in leads 2, 3, and AVF, we have upright P waves, QRS complex, and T waves in 2, 3, and AVF. You can see in V1, we've got that slightly biphasic P wave, and then in AVR, in a normal patient shown here, we can see this inverted P wave, QRS complex, and T wave. If we look over here, this is an area that is going to produce the reception of the AV node as the impulse comes down from the sinoatrial node. Here we can see a patient with AV node reentry tachycardia. And what has happened is we can see that the usual slow pathway in the reception area of the AV node is right next to a fast pathway in the AV node in a percentage of the population. Some 10 to 15% of the general population has this extra fast pathway, so that if, say for example, a premature atrial contraction shows up while the regular slow pathway is in its refractory mode, it will simply hop onto the fast track and initiate this AV node reentry tachycardia. This of course happens because the slow pathway is busy. You're an electrical impulse and you're driving down the turnpike, you're in a hurry, you're late for an appointment, and you can see that the cash-only lane on your right is already busy. You don't have time for that, so you go ahead and hit the gas and then take the pike pass lane only. That's the fast pathway, and that is what happens in nodal reentry tachycardia. Here's what that looks like electrocardiographically. We have a P wave, a QRS, a T wave, the same here. And then because the sinus node, the slow pathway, is busy in its refractory period, it's trying to get things ready for the next cardiac cycle, this premature atrial contraction, sometimes called APCs, shows up, and because the regular slow method is in refractory period, it initiates that fast pathway that occurs in 10 to 15% of the population, and so now we have a supraventricular tachycardia. Let's look at this 12-lead EKG. Here we can see we've got a QRS complex on this hatch mark, so we've got 300 and 150. This appears to be 2 to 3 small boxes faster, so we're going to say our rate here is 175 to 180 by my estimation. Now we go to lead 2, and we're going to look for sinus P waves. Now, when we say sinus P waves, we know that they're upright in 2 and upside down in AVR, but they also should be distinct and uniform in appearance and size and shape and so on. And so when I look here, I can't see for sure if that is a P wave or just a bit of artifact, but it looks different than this here, and I can't tell if this is a P wave or the end of the T wave. When I look for confirmation up here in AVR, that is of no help either. So here we have a QRS, we have the ST segment here, and then what looks like an inverted T wave, and then another QRS, so we do not see any distinct P waves. When we look in the anterior leads also, it appears that there is either a T wave and a QRS complex, but no P waves. With that rate of 175 to 180, narrow complex regular tachycardia, and no discernible sinus P waves, we're going to call this supraventricular tachycardia. The other type of supraventricular tachycardia we need to talk about is caused by a direct accessory pathway between the atria and the ventricles. This produces an AV reentry tachycardia. And as we've said, because of this accessory pathway, the circuit is permitted to re-enter from the bottom of the heart to the upper chamber of the heart and initiate that reciprocating tachycardia that's similar to a dog chasing its tail. Now, one of the most important forms of this arises from a condition called Wolff-Parkinson-White syndrome, and it can produce a subset of tachyarrhythmias. In Wolff-Parkinson-White syndrome, there is an actual extra pathway called the bundle of Kent, so that when the impulse makes its way through the bundle branch and into the Purkinje system, instead of terminating with the depolarization of the ventricles, it makes its way up into the mid-lower junction, hits the bundle of Kent, and then initiates that reciprocating tachycardia. We can see here on the left, what's shown in this graphic is a very short P interval and then a slur on the upstroke of the QRS complex called the delta wave. More on that later. The AV reentry tachycardias, which are a subset of SVTs that are associated with Wolff-Parkinson-White, can also be broken down into two further subtypes, orthodromic and antidromic. Taking first orthodromic, ortho means straight or right, and drome means course, like the hippodrome or the horse track in ancient Rome. And so the straight track is going to be an impulse that comes down through the AV node, through the His bundle, the bundle branch, and then takes that accessory pathway and then re-enters it from the pathway back into the node. Because it takes a pathway that is parallel or consistent with the normal vector of the heart's electrical system, it produces a narrow complex tachycardia that you can see down here in V1. The antidromic version of the WPW tachycardia does just the opposite. Antidromic means against the way, and you can see how the electrical impulse comes down through the accessory pathway, comes back up through the bundle branch, through the His bundle, and through the AV node. Now, this retrograde conduction produces this wide bizarre QRS complex, which in V1, if you compare it with the other V1, you can see where in antidromic, that wide complex tachycardia looks a lot like ventricular tachycardia. Let's look at some 12-lead EKGs and see how these WPW syndrome tachycardias might look. Here we have a very fast, very regular, narrow complex tachycardia. And so here is WPW with an SVT, that's an AV reentry tachycardia. And because it's taking the normal or straight course of the heart's electrical activity, this is going to be an orthodromic reciprocating tachycardia. Note the graphic and how it's displaying the normal vector of heart's electrical activity, and then of course the narrow complex tachycardia. Here we can look at this rhythm strip and see a very wide complex tachycardia. This, of course, is going to be an SVT associated with WPW, and this is the antidromic reciprocating tachycardia, where the impulse comes down through the accessory pathway, back up through the ventricles, the AV node, and it creates that retrograde conduction creates this wide complex tachycardia. Also in WPW, with that extra pathway, if your patient does go into atrial fibrillation, which is numerous ectopic foci discharging from the atria down through the ventricles, that extra pathway is going to allow more of those impulses to be conducted through the ventricles. And so if there is a rapid ventricular response, you can see down below that it's going to create a very bizarre, very fast, wide complex tachycardia, and that's going to create a real challenge in terms of clinical management. So WPW is a particular syndrome, and so you can have the features of the EKG, which we'll look at here. Over here in lead 1, we can see that this P wave is super close to the QRS complex. That's because of a short PR interval. We can also see this little slur on the upstroke of the QRS complex both here and in AVL. And then, of course, we can see that the QRS complexes are pretty wide. There's at least 3 small boxes down in here. So this is the 12-lead EKG that represents a possible pattern for WPW. Now, whether or not a patient with the pattern goes on to have the syndromes associated with those tachycardias is a different matter. So we just reviewed the tachycardias, which by definition have to have a rate greater than 100. We talked about ventricular tachycardias versus those that arise from above the ventricle, and as such are generally going to be narrow complex. We broke them down into irregular and regular tachycardias that come from above the ventricles, and we've just covered atrial tachycardia, atrial flutter, and then SVT, both the nodal kind, which is more common and mostly responsible for paroxysmal supraventricular tachycardias, and then the AV reentry kind, which is more rare, thankfully, more difficult to manage, and can be associated with syndromes like WPW and its subsequent orthodromic or antidromic tachycardias. And what comes next, we're going to start working on the irregular manifestations of tachycardias that come from above the ventricles.